All right, good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Matthew Song, who will be talking about antimicrobial stewardship, prophylaxis, and surgery. At this time, I'm going to stop sharing my screen and turn the presentation over to Matthew.
Thank you, Chelsea. All right. Does everybody see my screen, the correct version, at least? Yeah. We take that as a yes. All right. So thank you, everybody, for attending Grand Rounds today. My name is Matt Song. I'm one of the infectious diseases pharmacists with the Norton Infectious Diseases Institute. And I'm also the co-lead for the Kentucky Antimicrobial Stewardship Innovation Consortium. And today I'll be discussing a topic that I work with a lot in my current practice, and that is antimicrobial prophylaxis and surgery. And so at the completion of this presentation, I'd like for you all to be able to explain some of the considerations that we have when it comes to making antimicrobial selection, timing of administration, and duration of antimicrobial prophylaxis. Additionally, I want to address a common question that comes up in practice regarding the prophylaxis for patients who are already on existing antimicrobial therapy. And so to start off with this presentation, I just want to talk about the broad goals of antimicrobial prophylaxis and surgery. And so first and foremost, the number one thing we want to do is we want to prevent surgical site infections. And in doing so, preventing those surgical site infections, we can also prevent some of the related morbidity and mortality associated with them. Additionally, in patients who do get surgical site infections, they often go on to require more prolonged hospitalizations or readmissions, or just in general, additional healthcare resources are needed to treat those infections. And so anytime we can stop or prevent those infections, we can reduce the duration and cost of healthcare as well. Because we are providing additional intervention in the form of antimicrobial chemotherapy, there is the potential to produce adverse events, and so we want to be very cognizant of what those might be and take any efforts that we can to try to minimize those. And additionally, since we are talking about antimicrobials, there's always the inherent risk of antimicrobial resistance. And so when we're selecting these agents, we want to pick ones that perhaps are taking into consideration the propensity or the consequences that might arise from inducing resistance to that, and then combining and partnering with our infection preventionists to not only prevent the de novo synthesis of that resistance, but then also the transmission of that beyond just the individual patient, but to the hospital and the community as well. And so with all of these goals in mind, the specific characteristics that we have when selecting antimicrobial chemotherapy or antimicrobial surgical prophylaxis are listed here on this slide. The first one being, we want to pick an agent that's going to be active against the most likely causative pathogens. And when it comes to surgical prophylaxis, the potential pathogens are usually dependent on the specific procedure that is going to be performed. But generally, when it comes to our two most common wound classifications, where most procedures will fall, clean procedures and clean contaminated procedures, for clean procedures, we're focusing mostly on skin flora, and that's going to be mostly gram-positive bacteria, the big ones including strep species, but then also some staph species, including Staph aureus and coag-negative staph. As we move from clean procedures, where just the incision is in the skin, to clean contaminated procedures, where there might be controlled entry into some of the non-sterile spaces of the body. Procedures like these include colorectal surgery or solid organ transplant. We start to see additional organisms become significant when it comes to surgical site infections, including gram-negative bacilli and enterococcus as well. And so that's the broad concepts that we want to take into consideration when selecting. But when it comes down to that specific agent, we often go to our primary resources, which tend to be guidelines. The most useful or the most commonly utilized guideline when it comes to identifying a specific agent for surgical prophylaxis, it's going to be the 2013 multi-society guidelines. Those are endorsed by, I have all the acronyms there, but those are the American Society of Health Systems Pharmacists, the Infectious Diseases Society of America, the Surgical Infection Society, and the Society of Healthcare Epidemiology of America. And so in that guideline, I have a screenshot for you on this slide here. And essentially what you see is that they list out the types of procedures, and they first group them broadly according to really like the organ the organ groups, so like cardiac, thoracic, but then within those broader categories, they have the specific procedures listed. And for each of those procedures, they're going to offer recommended agents. In all instances, they usually have several recommended agents that are available with really no preference of one over the other. In addition to that, they also offer alternatives, and the alternatives are typically in patients with severe beta-lactam allergies. And so this is a great resource, but I will mention that I also find a lot of utility when looking to some of the individual specialty society guidances. A good example of that would be when it comes to C-sections or hysterectomies, the American College of Gynecology usually has a lot of specific guidance that is very similar to what we see from the 2013 guidelines, but they're often a little bit more newer and recent and will take into consideration some additional research that has come, that has been produced since the guideline actually came out. And really, to illustrate that point a little bit further, I just want to reemphasize those guidelines came out in 2013. And so, the takeaway here is just check your dates. So start there, but in some instances, I would say look for your alternative resources just to make sure there isn't anything else that has been produced more recently that can point you in one direction or another. A good example how I think there is some stuff that points in one direction over another is going to be when it comes to colorectal surgeries. And so from the little screenshot that I have for you on my slide here, you see that similar with colorectal surgeries, they give a bunch of different options. But traditionally, a lot of places gravitated towards sulfoxetine, and that's one, it checks that box. It's a recommended agent. It has demonstrated efficacy, and it provides activity against the organisms you're most concerned with, including gram-negative bacteria and then obligate anaerobic bacteria. But what we've seen is that since 2013, there's been some pieces of data that might hint that alternatives are actually preferred over sulfoxetine. And just to go over that briefly here, the first large study came out in 2013. This was a study of 34 hospitals in the Michigan Surgical Quality Collaborative with roughly over 4,000 patients. And what they did is they reviewed all patients who underwent elective colectomies, and they compared the surgical site outcomes according to the different antibiotics that they receive for antimicrobial prophylaxis. And looking at my figure there here, so what they did is that they looked at non-skip compliant choices, and then they compared all the individual skip compliant choices to those non-skip components. And so you see that the 1 odds ratio is highlighted in the center of that figure. And I also have highlighted for you sulfoxetine and cefazolin and metronidazole. So you see that when it came to sulfoxetine, there was actually no difference in the odds ratio for surgical site infections compared when sulfoxetine was compared to non-skip compliant choices. However, when you looked at cefazolin and metronidazole, there was a statistically significant reduced odds risk for developing a subsequent surgical site infection with using that combination over cefazolin and metronidazole. And so, you might look at this and say, hey, this is just an observational study. I don't know if this is enough to make me pick one over the other quite yet. So that's what I thought too. But then, I kept looking, and then there was another study too that came out around 2013, and this was data from 112 hospitals from the Veterans Affairs Surgical Quality Improvement Project. This is almost 6,000 patients, and in a similar methods, what they did is then compared the risk of all the individual antimicrobial surgical prophylaxis options to a reference agent. And then this particular study, instead of non-skip compliant choices, they used cefazolin metronidazole as the reference. And then you see here, when looking at sulfoxetine, again, they found that there was or rather similar, they found that there was a statistically significant increased odds of developing a surgical site infection. And if at this point you're not quite convinced yet that this is actually something, there's even larger study that was published in 2016 that was, again, it was an observational cohort claims database study, but had over 90,000 patients in 445 hospitals. Similar methods here. What they did instead, though, is that they used 3 definitions for surgical site infections, one including only ICD-10 codes represented by the column that's most close to the left. And then the middle column, they combined ICD-10 codes and then billing codes for wound cultures, represented with the group of columns in the middle. And then lastly, they looked at only wound billing cultures. So they here the reference was cefoxitin, and then highlighted in red for you again on this figure is that the combination of cefazolin and metronidazole, with every definition that they used, had a statistically significant reduced odds ratio. And so this was something that fueled us, at least locally, to make a change from using cefoxitin to cefazolin metronidazole on order sets. But again, really the takeaway I wanted to emphasize here is that don't just follow guidelines all the time, also see what else is out there. The next major consideration that we have when it comes into selecting our antimicrobial prophylaxis is going to be dosing and administration times, with the ultimate goal of making sure that when we cut that patient initially, we have enough concentration of drug in the serum and tissue that's going to be able to prevent contamination from holding on and becoming like an infection. And so when it comes to dosing, really we go back to that same 2013 guideline. In addition to that table where they provide all the individual selections, they also have this nice dosing table that gives you recommended dosing. And as for the most part here, it's all flat dosing. There are going to be some instances where you see weight-based dosing, like you see for cefazolin right there. At least in adults, it's always weight-based dosing in pediatrics. And there's some other specific agents that are going to have weight-based recommendations, such as the aminoglycosides and vancomycin as well. The next big component of ensuring that we have adequate serum and tissue concentrations, though, is going to be that timing of infusion. And I think anybody here who's worked in antimicrobial prophylaxis and surgery, we know that there's long been this recommendation that we want to infuse these drugs close to the time of incision. And then often the number that we hear is that we recommend we administer the antimicrobial prophylaxis within 60 minutes prior to incision, with some additional considerations of our longer acting agents, or rather our longer infusion time agents such as vancomycin and levofloxacin. Because of those longer infusion times, a wider window has been recommended, which being 2 hours. And what I really wanted to do then is kind of just emphasize some of the data that went into making that recommendation. And to me, one, there's a lot of data throughout the years that have somewhat replicated these findings and reinforced that this is probably the right thing we need to do. But the one that I really like is this early study from the early 90s that what they did is that they compared infection rates. And they compared them to different time intervals in which antimicrobial prophylaxis was administered. And so looking at this figure at the y-axis, you see that that's infection rate. And then the x-axis is going to be the hours of infusion. There's a big black arrow there on the bottom of the x-axis, and that's pointing to when a patient got their surgical incision. And then going towards the left, that's going to be the hours before incision in which an antibiotic was administered. And then going towards the right, that's going to be the hours in which antibiotic was administered after incision. And so when you examine that, you start to see there as a pretty clear gradient, or a pretty clear trend that develops. Is that essentially the further you get away from that incision time, either before or after, that risk of that risk of surgical site infection rate appears to go up. And so for me, this has been really one of the better things, I think, to graphically explain why we like to get that within 60-minute infusion time. The next major piece of consideration when it comes to making selection of our antimicrobial prophylaxis is going to be safety. And for this safety, what I really want to circle back to is that graph from that guideline. You have your recommended agents, remember, there's usually several there, and really there's no one that is preferred over the other, except perhaps maybe in colorectal surgeries, based on some of the information I just presented. But then there's always those alternatives, and I really want to emphasize they're alternatives for a reason. And so how good are the alternatives? Well, recently there's been a lot of investigation into the effects of penicillin allergies, and going back to those alternatives, they're recommended in patients with severe beta-lactam allergies, which is a little bit non-specific because you have a bunch of different kinds of beta-lactams, including cephalosporins and penicillins. And so historically, we've been hesitant about using cephalosporins in penicillin allergic patients because of a risk of cross-reactivity. But now we're seeing outcomes data demonstrate to us that when we use alternatives such as clindamycin or vancomycin specifically in that study, in those patients with penicillin allergies, you saw that there was actually a 50% increase in the rate of surgical site infections. And so that has really caused us to look at, whether or not we need to be reacting differently to these patients with penicillin allergies nowadays. And really a big driver of that is because when we look at these patients with penicillin allergies, most of them are not real. Most of them, they report these histories that are not truly consistent with real IgE-mediated reactions. And in a lot of situations, in most situations, in fact, you can give those patients penicillin allergies. But even now, there's been further guidance on what to do with penicillin allergy patients. And we now know that a lot of the cross-reactivity that we see has to do with the chemical structure, or at least portions of the chemical structure. And when it comes to cefazolin, which is actually our most commonly recommended antimicrobial prophylaxis agent, the chemical structure is actually so different from penicillins that in a recent guideline that was produced by the two major allergy societies in America, they went ahead and said that even in patients with true penicillin allergies where there is anaphylaxis, you could administer cefazolin just like you would in anybody else. And so I think with that in mind, that really reinforces that when it comes to these patients, we should find very little reason not to give cefazolin and hopefully give our patients the best chance to not have a surgical site infection. And then the last component, it deals less with the goal of preventing those surgical site infections, but more with the goal that we're making sure that we're not creating new problems by trying to solve our old ones. And so this has to deal with administering for shortest effective duration, so we don't give them an increased risk for adverse effects, and we also minimize the risk for development of the emergence of drug-resistant bacteria. And then also because these agents, there is healthcare costs, we want to be good stewards, and we don't want to spend money that we really don't need to. And so when it comes to duration of antimicrobial prophylaxis, we actually have a couple major guidelines that have reinforced this recommendation that is not always accepted very well by everybody in the surgical space. But the really speaking, I guess, of the devil, like there was, I think it was like last week or 2 weeks ago, there was an updated guideline that was endorsed by SHEA, IDSA, and then also APIC on the prevention of surgical site infections. And they reinforced this recommendation that after the surgical incision has been closed, you can stop prophylactic antibiotics. And this is similar to a recommendation by the 2017 CDC surgical site infection guidelines as well. I will say, though, that although this is like, the recommendation, I would say, from the major society guidelines, this has not been met without controversy. And one good example of that controversy comes to orthopedic procedures, specifically total joint arthroplasty. And so in response, actually, to that 2017 guideline, the American Academy of Hip and Knee Surgeons and the American Association of Orthopedic Surgeons, they put together essentially a white paper, like a position statement of sorts, and said they provided a recommendation that was said that we neither disagree nor agree with the CDC. They went on to say that, and when we look at the data, the data doesn't really show a benefit with the addition of prophylactic antibiotics beyond the time of the closing of the incision. But they still were hesitant then to recommend that they do that, though. Instead, what they did is they cited the limitations with the current data. They say, hey, some of this is observational, a lot of these are old, these are maybe some of these are RCTs, but they don't have enough people. But to their credit, a lot of times we identify problems and, we walk away from them. But to their credit, they identified the problem, but then also offered a solution. So they went ahead and funded a very large ongoing study. And this is a study that's ongoing right now, multi-center. It's a randomized controlled trial comparing just preoperative to 24 hours of post-operative antibiotics and elective total knee arthroplasty. It's expected to have 8,000 patients and actually expected to be completed October of this year. And so at that point, that will actually be the most significant, or rather the strongest single piece of data that we have on that particular issue. But, if what we see is that data tends to follow, or rather experimental data tends to follow observational data. And so I think the hypothesis should be that we shouldn't find any difference, although, I remain to be surprised. So that's one thing to take into consideration when it comes to duration, is that we will see some of that pushback from specific places as well. Another piece of major pushback that I often hear, though, when it comes to post-operative antibiotics is, hey, I just want to give antibiotics for just a few more days. What's the big deal? And I think with that, we actually have some good data to really precisely define what the big deal is. And so with our antibiotics, we're concerned about toxicities. We're always concerned about antimicrobial resistance, but we're also concerned about the simple drug toxicities. And we often just downplay those toxicities as being not that bad and unlikely to happen with just a few extra days of antibiotics. But in this one study that was published in JAMA in 2019, they specifically looked at the duration of surgical prophylaxis in surgical patients. And two toxicities that they focused on, they looked at AKI and C. difficile infection. And so with the two graphs in the middle of the slide here labeled E and F, it's AKI in cardiac and non-cardiac surgeries. Starting on the y-axis at the very top, it's when antibiotic prophylaxis was discontinued between 24 hours and 48 hours. And then middle, 48 to 72, and then at the bottom, antimicrobial prophylaxis continued for 72 hours or beyond. So you see that starting at the top, compared, the reference was being discontinued within 24 hours. You see that there's not that much difference, but as you moved more and you got longer and longer antimicrobial prophylaxis, you started to see increased risks with AKI in cardiac and non-cardiac surgery, with statistical significance with the confidence intervals completely above 1. And then also you saw that with C. difficile infection as well. So when it comes to post-operative antibiotic prophylaxis, really summing it all together, we don't have good data that really demonstrates that it's going to provide any additional reductions in surgical site. And we do have data demonstrating that the risks for toxicities are going to go up as well, too. And so to me, I think that's a good points to make when you're reinforcing whether or not we should follow the recommendations from the major societies. All right. And so before I finish with my discussion today on antimicrobial prophylaxis, I just really wanted to address a common thing I encounter when it comes to what to do with antimicrobial prophylaxis, and that's going to be this statement. Like, hey, they're already on antibiotics. Do we really need to give them more antibiotics right now if they're already on antibiotics, if they're going to get surgery? And to really answer that, there's not a great amount of data, but what is available first primarily comes from that 2013 guideline. And let me just read what they say here for that particular situation. They say, in patients receiving therapeutic antimicrobials for remote infection before surgery, should also be given antimicrobial prophylaxis before surgery to ensure adequate serum and tissue levels of antimicrobials with activity against the likely pathogens for the duration of the operation. The agents used therapeutic are appropriate for surgical prophylaxis, administering an extra dose within 60 minutes before surgical incision is sufficient. And so that's not a formal recommendation. There isn't like any cited data supporting that. But to me, that is a sound thought when it comes to what to do with these patients who are on antimicrobials. And for me, when I think about that, I kind of go back to this graph. Essentially the situation in which you have a patient who's already been on antimicrobials, but then subsequently needs surgical prophylaxis, that's essentially the same thing as them receiving, their surgical prophylaxis well beyond 1 to 2 hours before the incision. And so from here, we saw that, they kind of grouped everybody together for receiving antimicrobials beyond 2 hours. But we do see that the risk for surgical infection does go up after that. And so in that situation, I would say the additional antimicrobial prophylaxis is warranted to reduce that risk for surgical site infection. And still that's not direct data. And so we want, anytime we can get like outcomes data, that would be good. Unfortunately, not a lot of that exists, but there is this one piece of data that I found that has helped informed on this. And this was a prospective cohort study on vascular graft implant patients. And so they had 438 patients in this cohort study. Most of them got like only perioperative prophylaxis, but a few of them, a small amount of them, were already on antibiotics prior to their vascular surgery. After multivariate analysis, they found that inadequate perioperative prophylaxis was associated with a higher risk for developing a vascular graft infection, which is maybe like a subset of surgical site infections when it comes to this population. I would say it's probably like your equivalent of your organ space surgical site infection. But the reason that they had inadequate perioperative prophylaxis was primarily driven because patients were already on antimicrobial therapy prior to surgery. And so another way to look at their data, when looking at patients who only received perioperative prophylaxis, you had that 413, 32 of them went on to develop a vascular graft infection, representing 7.7%. But then when you looked at patients who were already on therapy, there's only 23 of them, but like almost half of them went on to develop a vascular graft infection. And when they provided additional information about that group, they determined that 65% of them had inadequate perioperative prophylaxis. And so a lot of that was driven because they did not get those extra doses close to the time they had surgery. And so, we have the theory, and now we have a little bit of outcomes. And so when it comes to that patient population, I usually say, hey, just go ahead and give them more antibiotics. I think the benefits are going to outweigh the risks there. And so in summary, when it comes to those considerations for antimicrobial prophylaxis selection, you want to target your likely pathogens and then also use antimicrobials with established efficacy. You want to administer those antimicrobials close in timing to the incision within 60 minutes, usually, to get those good concentrations to really prevent that infection. Assess your allergies appropriately. A penicillin allergy should not stop you from giving cefazolin. And then stop prophylaxis to ensure safety once the incision is closed. In certain situations, in select situations, there can be additional discussion, but for the most part, most patients should be fine to receive that. And then lastly, if the patient's already on antibiotics, do all of those things anyways. And so that is going to be the conclusion of my presentation. What questions can I answer for everybody?
I have a question, Matt.
Yeah.
So you talked about how cefazolin and metronidazole in those studies seemed to be better than cefoxitin. Just from kind of your review of that, what were some of the reasons that they noted for that difference?
So it's really, there's been two main regions that have been pros, but to me, they're kind of the same reason. And it's all centered around the idea of like, so you can look at it two different ways. So one, you can look at it as anaerobic efficacy. And so there's long been a concern that anaerobic resistance has been increasing with cefoxitin, but a lot of that is concentration based. And so the other consideration is that the kinetics of cefoxitin are not ideal for antimicrobial prophylaxis. There is one study, and I can send it to you. I didn't present it here. I thought about it, but there was like a lot of terms that I would have had to explain that I just didn't want to. But there was, it looked at essentially probability of target attainment with ertapenem, ceftriaxone plus metronidazole, cefazolin plus metronidazole, and cefoxitin. And really, when it came down to it, like cefoxitin looked bad. Like it just did not achieve high concentrations, and it did not maintain concentrations. Another thing to consider when we're comparing the two is that metronidazole, after you get your concentration, your half-life is relatively long. Long enough to the point that we don't usually ever recommend redosing it. Cefazolin, we typically do it 4 hours. Cefoxitin is about 2 hours. But when you look at that, like it just, your window for it to stay above in the concentrations that you want, it seems it's much more difficult with cefoxitin.
Gotcha. Yeah, that makes sense. I wasn't sure if it was a spectrum of activity issue or kind of.
It is because the MICs are elevated, but maybe you can overcome them with concentration. So it's it's kind of both.
Well, thank you.
Yeah.
Okay, well, if there's no more questions, I want to thank Matthew for this wonderful presentation and invite everybody back to join us for next week. Thank you.